Hello, and welcome to the 2022 NNLM Virtual Symposium, Advancing Engagement Through Research, New Trends and Opportunities. I want to thank the NNLM Regional Medical Libraries, offices, and centers that contributed to the development of this symposium. Before we begin, I would like to note that this session is being recorded. It will be made available after the symposium for 30 days on the symposium website. After that, all recordings will be transferred to the NNLM YouTube channel for later viewing. Please click the chat button to ask any questions that you may have. We will read them as the questions arrive as well. If you would like closed captioning, please click the CC button for live transcription. Our first keynote presentation is Trust in Science and the Impact of COVID-19, featuring our guest speakers, Daniel Mullins, PhD, and DeJuan Patterson. Daniel is a professor and chair of the Pharmaceutical Health Services Research Department at the University of Maryland School of Pharmacy. He is founder and executive director of the University of Maryland Patient-Centered Involvement in Evaluating Effectiveness of Treatments, also referred to as the Patients Program. He is the lead for the Community and Collaboration Core of the University of Maryland Institute for Clinical and Translational Research and co-lead of the CNC Core of the Johns Hopkins CTSA. DeJuan Patterson is an advocate and social impact consultant with the Bridge Advisory Group. Mr. Patterson leverages his unique background as a grassroots leader in community and government affairs to be a bridge between community, government, nonprofit organizations, and private companies. DeJuan provides necessary education and technical assistance on patient-centered engagement to community members and practitioners to create a mutually beneficial relationship that will result in better health outcomes. Everyone, please welcome Daniel and DeJuan.
Great. Thanks very much, Tony. I'm going to go ahead and share my slides. In the spirit of the Patients Program and the way in which we partner, we always start with the voice of a patient or a community member. And so I will not be starting us off today. DeJuan will be kicking us off. DeJuan?
Thank you, Dr. Mullins. Good afternoon, everyone. My name is DeJuan Patterson, and I will start off with like my journey to advocacy and how I got here. My journey can be traced to a single event back in 2005. In 2005, I was on my way to my senior year in high school, and I was nearly fatally shot. Being in Baltimore, experiencing gun violence nearly left me completely paralyzed and also no longer with us here today. Coming from that severe gunshot wound to the head, that kind of put me on a path to really understand what contributed to youth violence and aggression. At this time, I had a lot of questions and very few answers. Therefore, that started me on a path to really wanting to be not only an educator, but an advocate, because at that time, I had to be my biggest advocate because of where I was. My family did not know what to do with a victim of gun violence or severe head injury. My school did not understand it, let alone community and public safety. From that experience, that put me on a path to really start to develop youth programming that helped to address some of the violence and aggression that tends to happen inside of young people in front of the gun, as well as the young people behind the gun. Through that community organizing, I created community engagement programs, policies, working with public service institutions from education to the criminal justice, the Maryland criminal justice systems for juveniles. Later, that experience catapulted me into public service. Working on Capitol Hill, I realized my passion was always about continuing the advancement of quality of life for people in underserved communities or some of the young people who feel disempowered. From that experience on Capitol Hill, I learned that if I wanted to be even more transformational and see immediate results, I had to go a little bit lower inside politics, which was the system of city government. Those experiences really capture a really unique part of my life, because now I was able to infuse my grassroots advocacy work of promoting healthcare and higher education equity, but now also working with the institutions that's driving the agendas, that's crafting policies that impacted a lot of those communities. During that time, I've learned how community well-being is holistic, and we have to address it holistically. That's where I've seen some of my contributions going with working with Kennedy Krieger, increasing health access to low-income families who have children who suffer from autism-related disorders. Then I came to meet Dr. Mullins in the patients program, and it started out from a simple panel discussion for Pops and me, addressing African-American males and the programming in which they could benefit from, to a similar conversation where we built rapport and see how we can align both of our priorities and passions to a way of common value and progress. Do all those experiences really set the pace for me to be a credible messenger? So you'll hear a little bit more about the importance of a credible messenger, what a credible messenger is, and why it's important to work with a credible messenger. Lastly, I'll give you a definition. A credible messenger is someone who's a trusted neighborhood leader, an experienced community advocate with relevant life experiences to help community members transform their attitudes and beliefs around a particular public policy issue or given research topic. So as it relates to this, our discussion today on trust inside of health and research as it relates to COVID-19, I am DeJuan Patterson. I help to understand a patient's voice and a community member as we dive further into the discussion. And next, I will talk about the learning objectives. The learning objectives, one is to describe a continuous evidence-based process for patient engagement to enhance trust in medical and scientific research. Number two, introduce the patients program at University of Maryland, Baltimore School of Pharmacy. Number three, define the role of a credible messenger. Four, motivate institutional change for trustworthiness. And this right here is a polling test, because we would have this thing interacting. We love to see people engaging, interacting, and checking, making sure you hear it. Question 0. On a clear day, the sky is one of those singular options right there. And you can go to the bottom of your screen where you see questions and quizzes, and it should pop up where you're able to select an option. So without further ado, take this moment to select one of your choices. I wish we had a little bit of a Jeopardy music going on there.
And Tony, can you help DeJuan and me know when it looks like a bunch of people have voted and then?
Sure, we currently have about 140 some people who've responded.
Okay.
So
do you want to close the poll, DeJuan, and look at the results just to?
Yeah.
Okay. A couple people in the chat are singing your Jeopardy song for you, DeJuan, just so you know.
Okay, well, thank you for all of the really large participation. So I know I have your attention and you're engaging. So on a clear day, the sky is, majority rules are saying, is blue. So thank you for all for participating in that poll. It's a test, and throughout the presentation today, we will be asking you a few more questions. And one right now is, what do you think is the biggest challenge to engaging diverse patients in research? 1, access to information about research studies. 2, health literacy of potential participants. 3, distrust and mistrust in science. Final choice, research protocol requirements, i.e. exclusion and criteria. So if someone want to cue up that Jeopardy music as we get all you guys and girls to participate, and I'm selecting one of the biggest challenges to engaging diverse patients in research. And thank you to our great moderator for keeping me up to date on time and participation in the polls.
Currently, we have about 139 participants. I'm happy to end the poll and share the results now if you'd like.
Sure. Okay, so we got at 68% people says mistrust, distrust and mistrust in science. Runner up will be health literacy of potential participants. And third, we have access to information about research studies. Last, we have research protocol. So thank you for participating.
Well, let's talk a little bit about this because we have a bunch of people here who are aligned with the National Libraries of Medicine. Their job is to help access information, which is the third, as you said, also to help improve health literacy. I think sometimes it's not clear kind of how can they have an impact on distrust and mistrust in science, especially in the current environment. And so I just would encourage all of you who are here to realize that this is part of the challenge. Is there's so much information now that people can simultaneously access information and access misinformation, which leads to distrust and mistrust. And so I hope that we could have some comments in the chat or questions about how those of you who align with the National Library of Medicine's objectives can help to address this distrust and mistrust, same as we try to do in academic institutions. I'm going to take it over for a couple of slides now from DeJuan. DeJuan is one of our community partners. We have patients and have community leaders like DeJuan who really help us to think about how we could do research differently. And why is that so important? Well, it's because research is not trusted in the United States. And part of the reason for that is that people don't understand research. By engaging patients and by engaging community leaders, we can make research more meaningful by framing a question that patients and community members care about, understand. And when we do that, then when we answer a question through research, people will understand what we've learned. They will understand the answer to that question because they understood the question and why it was important. It's also important to build trust. Part of the reason there's distrust and mistrust is because we haven't built trust in communities. And so how do we do that? It's through bidirectional learning on a daily basis. DeJuan and others teach me so much about their communities and how we can build trust and how we can do research to improve the health of their neighborhoods and their communities. But it has to be bidirectional. Everybody needs to be learning together, and we need to learn how to learn differently. We need to learn how to do research differently. I point to the Patient-Centered Outcomes Research Institute, or PCORI's rubric, and the principles of engagement that they put up as reciprocal relationships, the idea of co-learning, what we call bi-directional learning, the idea of partnerships and building trust, but also as part of that, to have a transparent conversation and to be honest. And I think when we're honest, it allows people to trust us more, and it helps for people to trust as opposed to have distrust or mistrust. When is patient engagement appropriate? You know, a lot of times people talk about, we really need to talk to people up front, or you really need to make sure you talk to people at the end. And what we've learned is that it has to be a continuous process. And it's not just about in the context of an individual project, but it really is about engaging people even outside projects. So for instance, the church that we work with up in the Mandama neighborhood, we have pre-engagement meetings with them to learn how they would like to partner with the University of Maryland, Baltimore's Patients Program. We talk with individuals like DeJuan, how would you like to partner with us before we talk about a specific project like the project that we recently completed with DeJuan and colleagues at the Food and Drug Administration on COVID-19 testing. We also then need to have early engagement to make sure that people understand what we're doing. We need to make sure that we keep our partners updated. And we need to make sure that not only that we try to translate, but that we ask individuals like DeJuan or patients who are advising us on an individual study, how can we translate this so that people from your communities would understand why this is meaningful and how it could help them to improve their own health, the health of their family, and the health of their neighborhoods and communities. And how do we disseminate in a way that builds trust rather than confusion? And again, for those of you who are aligned with the National Library of Medicine, you have such an important role in helping us to disseminate appropriately to reinforce trust. The Patients Program at University of Maryland uses a 10-step framework. This 10-step framework was developed a decade ago by myself and some colleagues, in which we broke down the research process from the idea of all the things that we might study to prioritizing what research is most important. Federal agencies do this on a regular basis. And so we have to have a similar prioritization process for the research that we support. How do we then, when we decided what to study, frame it in a question in the patient voice so that people would understand it? And then as we're conducting the study, as we're doing the study, how do we make sure that we're measuring things that are important to patients as well as their community healthcare providers? How do we make sure that it's scientific so that we have a conceptual framework, that we have an approach to analysis and data collection that are both scientifically appropriate, but also meaningful to those who would participate in the study? And then how do we make sure that we review and interpret results with people with lived experiences so that we can translate and disseminate in words that people would understand and would use to make more effective decisions? And having developed that 10-step framework with input from our community partners, we then heard from our community partners that 10 steps is too many. And so they helped us to break it down into planning, research, doing it, and delivering solutions. And we learned that talking about delivering solutions rather than returning results was more meaningful in a lot of communities. Because if I have a health problem, I'm not looking for an abstract from a peer-reviewed article, I'm looking for a solution to my health problem. And so how do we translate what we do in research into solutions that people can use to improve their health and the health of their communities? The way that we do it is through engaging individuals. And I want to talk about the levels of engagement, because it's not just engaging patients as participants in research, which is at the bottom of that list on the right, study participant. But how do we get some informal input? How do we get consultation from individuals who can help us to develop our protocols or a survey? How do we move towards collaboration with partners like DeJuan? How do we build partnerships between institutions, like the institution that DeJuan works for and the institution that I work for? And then how do we ultimately have our stakeholders direct what are the priorities for the research that we conduct? And I think if we think about this, not just in terms of how we conduct research, but how we disseminate what we've learned from science, that we really can have an improved process. Tony, I see that there are some things going into the chat. Please feel free to interrupt me if there are questions for DeJuan or me.
Yeah, there are a few people that raised their hands. I just wanted to let them know that if they have a question to ask in chat, so I'll read them aloud. I did see a question from Sally Gore that says, when we say and believe that people don't understand science, what is this saying about our education systems nationwide? And what can we do in our roles as professional health sciences librarians do to address this issue? So, and I responded, since you're both not health sciences librarians, to maybe ask and have comments in the chat box from other health science librarians with potential ideas on top of that.
Great. I will offer something up and then
Sure.
turn over to DeJuan, but I would also offer up that as librarians, you also could talk with individuals like DeJuan and say, look, this is how I would discuss this. Do you think that would resonate in your community? So a lot of what I do when I'm talking with someone like DeJuan is really try to figure out, like, how would I phrase this if you're not around to help me, right? And DeJuan is there and helps us quite a bit, but I would like to think that I don't always need him there, that if I'm out in the community and somebody asks me a question, that I'm learning from DeJuan how I can language and how I can explain. Part of that, though, is that building trust. How do we help people to believe that what has gone through, for instance, peer-reviewed literature is credible and sound? How do we help people to know whether a source that's on the internet is a credible source or not a credible source? And I think those are the types of activities that people can do. DeJuan, what would you add to that?
Thank you. That's a great question. I think we will tie a little bit more information on ways in which we can be better partners to each other a little bit later on our presentation, but just understanding as credible information sharers, if we was just to use layman terms. As a public librarian, just think of you as a liaison, a bridge, so to speak, between institutions of research or academia and community. And how can you help to to eliminate some of this level of ambiguity, mistrust as it relates to research. And sometimes that is something as simple as education. Let's do an exchange of perspectives. And I'm a person that's always big on sharing perspectives and introducing new perspectives. And how can we align something old with something new to present something better in the future? So I would say for librarians and other practitioners that we have on the call, just meet people where they are, ask them questions of how they feel about research. And some of the things I've learned that oftentimes just the word and stigma of research feels like a dirty word. So how do we clean up the actions, behaviors, and attitudes as it relates to research from our current position? And I'm saying ours as a librarian. And as you will hear throughout the presentation, I use a lot of inclusive language. So when I say us, I believe it's us together.
Other questions that you want to go over with us, Tony?
Well, just recently, Paige added a comment of saying this is very similar to APHA's emphasis on engaging with trusted leaders in the community so that they can carry messages back to their communities and establish more trust towards researchers. On another note, she mentioned looking into the history of the IRB, which was very enlightening, and also sorry, it scrolled quickly, and also horrible in understanding some of the injustices in which mistrust and distrust is rooted in. And then Bradley mentions that there were several Pew Center surveys demonstrating the trust in public libraries, how science librarians could create more partnerships with local public libraries to help address trust in science.
I agree. I mean, I often realize that even though I work at a public institution, that members of the Baltimore community don't know that University of Maryland is a library that they could go to, right? They think of public libraries, they don't necessarily think of the University of Maryland, Baltimore. And so just even educating people that this is a public university and therefore our resources, are to be shared with the public. I agree. I do want to talk about this idea of pre-engagement, because many people talk about continuous engagement. And this idea of pre-engagement is something we've really embraced. Many people go when there's a specific project to partner with a community leader. And that community leader then is having to get to know you while you're in the middle of doing that project. The idea of pre-engagement is to talk with these community leaders about what they would want out of a partnership. What would the pastor of a church or, the owner of a barber shop or a local convenience store or a local health clinic want out of a partnership with University of Maryland, Baltimore, or the National Library of Medicine, or part of the network of institutions that interact with the National Library of Medicine. And really sitting down and not talking about a particular project that you're trying to roll out, but really talking about building that partnership up front. And then finding out, if I'm going into, quote, your community, how would you like me to enter your community? Right? In the same way that, when you enter someone's house, you try to enter respectfully. And so really having conversations about how to partner, how to go into a community, and how would you like us to keep you updated, and how would you like us to disseminate? So again, especially for those of you who are reference librarians or other types of librarians, I think we oftentimes push information out, but we don't take the time to ask, how would you like us to push information out to you? So being very mindful of that. At the Patience Program, and Tony mentioned at the beginning, it's kind of a mouthful of what that acronym stands for. The idea here is that individual patients aren't just study participants, but they're really involved in evaluating what we're learning as co-investigators on our projects. DeJuan would be listed as a co-investigator on one of our proposals that gets submitted to a federal agency or another funding agency. And our origins were a federal grant, and it was an original 5-year, $5 million grant that started the Patience Program. But in the third year, our community leaders, who are part of our steering committee, told us that we really needed to transform from a large grant to a program. if we wanted to do what we said we were going to do. And so we created a separate vision and mission for that. We have strategic plans that we're now on our third strategic planning process for our 3-year plan. And we really take this quite seriously. We did start, as I mentioned, with a large AHRQ grant, but that grant leveraged an earlier award from PCORI, in which we were contracted in the very first year that PCORI came into existence to conduct interviews on eliciting approaches to engaging what they refer to as hard to reach patients. So what typically we would refer to as underserved or underrepresented populations. And in partnership with groups like Bon Secours, Baltimore Health System, with Mount Lebanon Baptist Church and other anchor institutions in our city, we conducted these interviews, having those partners help us to develop our interview guide, and then leverage that to build the infrastructure that we now call the Patients Program. Our steering committee does, by design, have more people from the community than from the university so that the community can outvote us. And they do have decision-making power, not just advisory power. And in that process, then, we learned and continue to learn about building trust. And we have heard over and over that the best way to develop a research partnership is to have this long-standing partnership where we think about building trust by identifying potential partners and partnering, but making sure that we continue to explain to our partners what we're doing, to involve them in what we're doing, have decision-making authority on major decisions about how we operate, and by having bi-directional learning so that partners understand why we do research the way we do. In the context of doing searches, let's say using PubMed, how do we empower community members, or how do we work with them so that they're empowered themselves to do searches so that they don't feel that they're always reliant on us to do something? And I've learned a lot about this idea of partnering, and the idea of, I would always like to think that my partners don't need the University of Maryland Baltimore's Patients Program, that we've taught them enough that they could go out and do this on their own. But if we have a trustworthy partnership, we're probably going to continue to work together, even if, quote, we don't need to work with each other. How do we establish respect for one another? How do we learn to work together? And at times, how do we learn to argue, just like we would within any relationship? But argue in a manner in which we then try to come to an area where we hear each other, where we figure out how we can continue to partner and how we can continue to improve what we do. The terminology of patient-centered outcomes research comes from PCORI and AHRQ. In the NIH space, we oftentimes talk about community engaged research, or CENR, little n. And the idea behind this is within the Clinical and Translational Science Awards. Here at University of Maryland, Baltimore, I lead the Community and Collaboration Core for our Institute for Clinical and Translational Research. We collaborate under the Johns Hopkins CTSA, along with Morgan and Kaiser Permanente. And we've really built this collaborative process as NIH wants to see us, in which we are identifying the assets that all of the stakeholders bring. You'll hear from DeJuan in a little while how to partner and how to make sure that when you're partnering with the community, that you don't assume that your role is to go in and help them on what you think that they need help with, but really understanding that we all have assets that we bring to the table, and how do we leverage the assets of both communities and research intensive institutions. The goal then of community engaged research is to build trust. It's to enlist new resources and allies. And I think libraries are great resources for community members to have to understand what's out there. But then how do we communicate better so that people can leverage that information and use it? In the context of doing research, how do we avoid what's called helicopter research, where a group goes into a community, abstracts information or abstracts data or abstracts biospecimens, and then leaves? How do we avoid having people feel that they've been treated like guinea pigs? How do we learn from historical events such as Tuskegee and the journey of Henrietta Lacks? But how do we also acknowledge that these aren't just historical events, but they're contemporary occurrences in the context of research? And so how do we continue to change research so that it is more trustworthy? With that, I want to go to another polling question. Again, this is opinion, so what do you think is the best, or who do you think is the best person to recruit patients for research? Do you think it's primary care providers, primary care office staff? Do you think it's community members, or do you think it's people who look like participants but are from outside the community? And obviously we've kind of deliberately chosen our words wisely here, because these are strategies that people often use. They're all acceptable strategies. They all work in some circumstances and work not so well in other circumstances. So who do you think is the best person to recruit patients for research? Primary care providers, primary care office staff, community members, or people who look like participants, but they're from outside the community? Tony, how are you doing in terms of numbers?
We are currently at 124 people. One thing, as people are still working on the poll, I can give you a couple of comments that I saw in the chat. Community trust is very region specific, regardless of population mix. Healthcare systems work very hard to the local source of truth for surrounding communities. Their community outreach efforts are critical. This is especially prevalent in rural areas. Another person, John, mentioned there should be conversation with community members, not just about how we can interact with the community and what are ways we as researchers can do our work. There needs to be a conversation about what benefits the community and what their needs are that should influence the research. It should be a partnership, not just a meeting to figure out ways for researchers to do things different without considering community benefit. And then also, in addition, John Eldridge commented, we in New Mexico know all too well about helicopter research. So at this point, I'm going to end the poll with 151 participants, and I will share the results.
Great, thanks. Thanks very much for the comments. For all of you who are sending comments, this is how we learn, right? Is everybody brings their experiences, observations, and expands. Yeah, so you can see that community members was the most popular response, followed by primary care providers. I think that's consistent. DeJuan, I know that we were going to go to this later, but I think on this slide, it may be helpful to talk about the project that we did with the Food and Drug Administration and some of the personal observations that we had in our discussion. So this certainly is not information that came from the FDA or even information that came from the interviews that we did under the contract with the FDA. But I remember that we had several conversations while we were doing our research about COVID-19 testing, about oftentimes strategies where people were using people who, quote, looked like the participants that were trying to be recruited, but they were outsiders. And I thought maybe you'd share kind of some of your thoughts about why that might not always be such a great idea.
Absolutely. And this is a common practice that we see used across the board, whether it's research, education, politics, civil engagement. People often think that you could appoint someone to be the spokesperson for a SAC community because they resemble SAC community. However, I think the most important element that we tend to forget about is, do their attitude, beliefs, and experience represent that SAC community? And throughout COVID-19 and our journey during the COVID-19 research project, we noticed that was the very thing that was happening. There were people who may share the same complexion of the community, but did not share the same cultural experience. And therefore, it increased and amplified the level of mistrust as it relates to COVID-19, whether it's testing, vaccination, or information that was being shared. So it actually made public institutions and research institutions less credible. And that is something that we tend to overlook. And it's really important that we think about, as we all said in this, the best person to recruit a patient for research is community members that have either lived shared experience, they share similar values, and oftentimes the best representative is someone who have a few things that I speak on: trust and credibility, authenticity, and proximity. if you have a community member that have those type of attributes, it's really important. And lastly, this is one more element, because sometimes we think that a leader is someone who's just comes from a traditional job title or affiliation. As it relates to the community, you got to get someone with those attributions of trust, credibility, authenticity, and the other piece is progress. You have to have someone who's able to deliver results in a way that is mutually relevant and beneficial to set community members. And that goes into some of the things that we talk about in the next part of our presentation. If Dr. Mullins, you don't have anything to add, I was going to some of the things we already mentioned. What you should know about partnering with community to do research. Any community consists of diverse persons. And as you see on the PowerPoint, there is some people who share geographically, political, racial, academic, occupation, certain health issues helps to formulate a community. And it goes beyond the iceberg of complexion, which is really important for people to understand. And I'll give one example of that. So you should know that we can begin to shape our perspective on a diversity of community. We all come from a household and a family. So just think about how unique our DNA and experience is based on, just because we have the same last name, do not mean that we share the same lived experience. You look at your little sister, your big sister, your mom, your dad, it's so many different elements that contribute to your perspective. So just keep that in mind when you engage in community, see people as individuals. Lastly, next point is what you should know about partnering. Part 2, many Native Americans, African Americans, Latinos, and other minorities have a great deal justifiable mistrust of researchers based on research history. We all know some of those experiences that was previously mentioned, whether it's the Tuskegee Institute project, experiment, or was something as recent as the Henrietta Lacks. These are the things that contribute, maintain, sustain mistrust as it relates to researchers. So before you engage community in research, seeks to understand their current position as it relates to research. Know who the leaders are, what are the assets, what the needs are, and who are the stakeholders, which is really important, and it changes based on the region and proximity. Seek some advice from recognized community leaders, AKA credible messengers. This is something we touched on earlier, and I will always tell people that leaders do not always have to have your traditional title, affiliation inside a community. One thing that I would say that you can go to Miss Ann, she's had the long-standing ownership occupation of a house inside the neighborhood, so she got a level of historical information of who's who and a level of respect there. Then you also may have the barbershop owner or the barber who have a perspective that's intimate connections with said community members. Another point is be intentional about leaving the community better off than what you found them. That's something that's really, really important. That's the debt that we pay here, leaving us better than which we found it. Never approach your research from I am the Messiah perspective. No one is asking you to save them. We are here to share perspectives, and hopefully those perspectives help to change and save lives together. Evidence-based engagement methods. You got community partnerships, focus groups, key informed interviews, because sometimes people feel less intimidated when it's a one-on-one. See me singular like that. We got some high touch and high technology. So meet people where they are. And I always say that they may be physical proximity, but it also may be physiological. So meet people where they are is really important. Meetings, print items, social media, storytelling, which is one of my favorite, study advisors or partners, and surveying. And sometimes you may need a collection of methods together to reach people because of these two different ways in which people like to be engaged. Similar to education, people have many different learning styles. So something may be high touch, something may be high tech. Some people like to be able to see you. Unfortunately, the last 2 years, we couldn't touch people. But however, we tried to find ways to actually feel like you're touching, whether it's the breakout session to foster intimate engagement. Web-based platforms conduct interviews, focus groups, and that helps us to go across geographical boundaries, but also help people who may feel less comfortable with high touch during these times that we're in right now. Larger groups are feasible, smaller groups are easier for interaction, and map out the platform. Lastly, I would say that understand that sometimes the access to digital products and technology can be a barrier to some people. So you might have to pick up the phone. You might have to do that door knocking, do 6 feet in distance is really important. So meet people where they are is really important.
And yeah, thanks, John. And you were one of the community partners that really helped us to figure this out. So we consider the Patients Program to be a high touch engagement program. When we had to pivot during the pandemic, we really had to figure out how to use those different approaches that DeJuan mentioned. I think it's important to simultaneously acknowledge that that some people don't have access to virtual platforms, but also don't assume that people don't have access. Many adults do use web-based platforms, and almost all do have smartphones. So one of the things that we learned from our community partners is that we probably could get people to come into something like a Zoom meeting, but it wasn't like they had Zoom on their computer. And so how do you bring a community along? And the idea was to start out by doing things on Facebook. And so we let people know that the Patients Program would like to continue to engage you. And in our Facebook, we started talking about that we would like to set up some sessions to work with the community. We then started doing some fun activities. So we had some jam sessions. I learned this from another academic institution where they did what they called research jam sessions, right? Because a research jam session, somebody might go to a session on research, nobody's going to want to go to. So how do we begin to have some fun in which we begin to talk about what research is to get people more comfortable, allow people to talk about why they don't want to do research and listen, but then talk about how that might be able to be changed. And then we had to be prepared to train people. So how do we get people from Facebook or their iPhone to a Zoom meeting? And how do we staff that appropriately so people can know how to do that? What we wanted to do is make sure that we continue to embrace this concept of what we call a learning healthcare community. Most of you, if you are affiliated with National Library of Medicine, are familiar with the LHS or Learning Healthcare System model. And what we wanted to do over the last 5 years, pre-pandemic, during pandemic, and hopefully one day there will be a post-pandemic period, is to really bring that learning health system further out into the community, to shift the current model of thinking about when somebody comes into a hospital, how do we make sure that they're prepared for their discharge, to how do we prevent people from coming into a hospital because they're living healthy lives in their community. And we believe that the answer is to engage the community in figuring that out rather than simply disseminating information, so that we develop what we call learning healthcare communities, where communities learn how to be healthy. And what better partners than librarians to help communities to think through that. Again, many of you are probably familiar with the Institute of Medicine, now National Academy of Medicine's model for the learning healthcare system. And this figure from the kind of decade ago period where we really began to understand that so much of science falls away because the science gets published in peer-reviewed journals and never gets translated into evidence that community providers can use. And then because of what's happening in the healthcare setting, the patient experience is much worse in terms of health at the individual and population level. Because of all the missed opportunities, because of the waste of learning how to make people healthy, but not getting it into the hands of people who have to make decisions. And so how do we then begin to have more of science implemented in terms of improving health at the care experience level? How do we eliminate the kind of poor quality of health indicators by really getting information into the hands of individuals who could benefit most? And if you look at the original learning healthcare system stakeholders as defined in that report from 10 years ago, it seems to be the most of the relevant individuals who would be participating in helping a healthcare system like a hospital really to develop the highest quality of care. But one of the things that was missing from that was that the community wasn't really part of that process. There was discussions about the role of the community, but the community wasn't there. We were very fortunate then that we brought together a group of advisors to help us think through this. And so we invited people from learning health systems like Henry Ford, but also we invited people who knew about the concept of a patient-centered medical home. So Jennifer Baldwin from the local Blue Cross in the Maryland area as individuals. But we also brought in some of our community leaders and community providers. So thinking about our local federally qualified health center, Total Healthcare, how do we bring in their chief medical officer, Dr. Court? How do we think about a neighborhood captain? So at the time, Jackie Caldwell was the president of the Greater Mondawmin Coordinating Council, which is the coordinating council for the neighborhoods in the Mondawmin area. But then how do we bring in individuals who work in local or city governments, who understand what's happening in local environments? Or how do we work with churches? And in particular, we were thinking of our partner, Mount Lebanon Baptist Church. And in this particular case, the woman who serves as the head of their HIV/AIDS outreach services. And with these 6 individuals, really thinking about how to take the learning healthcare system model further into the community. As part of that, we developed a mission and vision statement for thinking about how we could support community engagement within all aspects of healthcare environments to foster health of individuals, families, and neighborhoods, and have this vision that community voices and community needs were really going to drive an equitable healthcare process and ultimately improve the quality of life of individuals and populations. And how do we think about information flow that's necessary for that vision to come from research into actual clinical care and the health of communities?
Daniel?
And I love the fact, oh, go ahead, Tony.
We had one question come in. How do all these people or their employers get compensated?
Yeah, so in our case, we're fortunate that we write grants and contracts that get funded. And so when we have individuals on our community advisory boards, we pay all of our advisors. One of the things that we're very proud of is all of our advisors get paid the same amount. So on this previous slide where I was talking about these individuals, whether you're the head of a ministry at a church or whether you're the chief medical officer of an organization, you get paid the same rate. And we always do pay our advisory board members. For those who are asking about guidance for that, I think oftentimes people point to things like, what do we pay for individuals to sit in on a study section for a federal agency? And so we use that as a benchmark. We actually pay a little bit more than the study section rate on a daily basis to our advisors. And then I would say that, for institutions that maybe don't write grants and contracts, that has to be then part of your budgeting process, that you can't expect community members to volunteer their time when the rest of us are getting paid to do our jobs. And I know, DeJuan, you have very strong feelings on that as well. So you want to add to what I said?
Yeah, Dr. Mullins pretty much answered that question. I think that is a really important piece that needs to be included, addressed inside industry practice. I know that we are accustomed to doing it because that's just our values and our culture with the patients program. I think that our hope, our vision is that becomes industry standard, and whether it's from the funding side, institutional grant makers, they will increase the budget and allocation to see the value of properly compensating everyone who's involved, because we know that community members, their lived experience is their expertise, as well as their access to social capital, helps to drive out relevant health outcomes. So they should be compensated in a way that demonstrated that they are valued.
Returning to the learning healthcare system on the left, To remind everyone, the learning healthcare system model suggests that we have data, but data alone isn't enough, and we need to take that data and translate it into knowledge, and that knowledge then impacts patient care. In the context of patient care, we gather new data, and that data then gets fed in so that we learn how to improve, health in a system sense. And in this project, we're thinking about then how do we do that in the community? And especially, what is the role of librarians in helping this cycle to continue out in the community, where the community has a certain level of health. And one of the things we could talk about where there are health disparities. How do we educate communities on what are the major health challenges according to the data that we currently have? How do we have conversations about why is it that we collect data? Because a lot of people don't like you collecting data on them. So why is it important for us to collect your blood pressure? Why might it be important for us to collect a biospecimen? But then also to talk about what are we doing with your data? Because the reason people don't want to give their data is if they think that it's being used against them, or they feel that it's benefiting another community, but not their community. And then how do we take those measures of health at the community level and raise awareness on what seems to be improving the health in communities that are getting healthier, and what seems to be the problem in terms of communities that have suboptimal health. So how do we raise that awareness? How do we then impact community health as we impact individual health? And then how do we continue to gather information in these measures of health? So that sounds conceptually quite good. The issue is that, again, we oftentimes think about what are the measures of health that we, whether it's an academic institution or the federal government, want to collect. And I think what we're now hearing is that we need to work with community leaders to figure out what are those measures that we should be collecting? What are the measures that the community cares about that they want to see captured? So we're not just capturing things that federal agencies want, but we're capturing things that communities want to know about so that they can become healthier communities. And I'm really excited about some of the work that we've been doing about building partnerships that are based in trustworthiness. Most of our articles these days are co-authored with a patient or community leader. So here's one where, as a result of that work that we did, Gail Graham, who is the head of the HIV/AIDS outreach service at Mount Lebanon Baptist Church, really helped us to think about building trustworthiness. And she said, one of the things that you have to understand is that sometimes we do trust you. And we hear, really good stories about what researchers want to do. But just because we trust you doesn't mean that you're being trustworthy. And I really felt that stuck with us. So we thought a lot about, a couple of years ago, this idea that the formation of a community academic partnership may suggest that community partners trust researchers. But that does not mean that the researchers are viewed as trustworthy. And so it's what we do with that partnership. DeJuan, did you want to add something here?
Yeah, I was I was monitoring the chat and the time, and just giving us some a moment for having an open discussion. If I may, I think that based on some of the questions we were receiving inside the chat, I think it would be beneficial to share my experience doing the FDA project we did together, because I believe that is a great example of a project where this worked well, particularly. We'll be going to not only trust and trustworthiness, but if we could skip down to the community partnership, community and academic partnership, the next slide, after this, the infographic, that one. So throughout this one particular project with the FDA, University of Maryland Patients Program, and myself and a few others, is a great example of how to really do this work. And it's not just centered around trust, but is inclusion of participation. And I'll give this example of how that journey went. Based on the relationship that myself and Dr. Mullins maintained throughout the years before COVID-19 actually happened, we had a level of maintained communication. So we are abreast of what's happening inside each other's lives, family, community, and culture, and stuff like that. So throughout our quarterly, monthly check-in calls, we shared some of the things that was a part of our reality, and mine's particular of how my family was drastically impacted by COVID-19 across 4 generations, to the point where it was from my grandmom tested positive, ended up in the hospital, down to my niece, who tested positive for COVID-19 that was not hospitalized, but I say about 1 in 3 was hospitalized, and it was super critical of COVID-19 information being shared. A lot of the information my family was getting was from social media. You know, the world shut down, pandemic has introduced social distancing. So a lot of the information was received from trusted sources within their peer network, which can be a really bad thing when you talk about misinformation, disinformation going on. A key example where some information went out there that Clorox would actually get away, will eradicate COVID-19. We also heard the cause of COVID-19 was because of 5G towers going out there. These are examples of misinformation and information manipulation that happened. So I came to be one of the most trusted sources between research institutions and my family to really deliver a lot of the information to debunk a lot of mistrust. So from that point, I had to hey, something needs to happen because I'm seeing firsthand my family and community members being impacted by COVID-19. My grandmother, a heavy critic of COVID-19, the vaccine, the testing, and all of that for. Throughout these conversations, it really shaped our research proposal aims and questions for the FDA for them to understand to understand COVID-19 communication strategies as it relates to Black and Brown community members, which was huge. And I'm trying to rush through this real quickly for the nature of time. But as a result, I had to bring in the attitudes and beliefs from my hypercritical grandmother, my mom, and some family members who have low health literacy and understanding to actually help to inform me what are the proper questions to use and how to hold myself accountable to maintain the trust and credibility that I have established with my community, but also help to establish and maintain the trust and credibility from my institutional partner side. Fast forward, both of these parties have held me accountable that, hey, we both have outcomes, agenda, and interests. How do we align those? And we found a nice, happy medium to align those. And community members felt that they were a part of something greater than themselves. They understood the importance of contributing to science and research. Therefore, they was pushing their beliefs and reshaping their perspectives to the point now my grandmother is a COVID-19 vaccine advocate. She's pushing people to say, and holding you accountable if you do not get the vaccine because of the impact it may have on your community. So we talk about a point of how we can shape and reshape perspectives into a way of mutually beneficial. Community members saw the value of participation. The institutional partners seen the value of participation, but not only participation, but holding that participation in a regard where it can pivot their research agenda to the point where you can see alignment between the interests of community as well as relevant outcomes for the institution. So that is an example in which I say that that we can use this approach to work together. And I know we short on time, but we will provide the PowerPoint so you can have some of the rest of the slides we did not get to cover. And I will hand it off to Dr. Mullins.
Yeah, so we close with one example of how we chose to do this is I got a call from, in the middle there, the gentleman with the 1906 t-shirt on is the pastor of Mount Lebanon Baptist Church. Got a call from him saying that they had a bunch of people up in the Mandama neighborhood who wanted to get vaccinated and they couldn't find vaccination sites. It's hard for us to remember that because now it's so readily available. But back in March 2021, it was very hard. We worked with them and we were able to get one of the chain pharmacies to come and set up a clinic there. They only wanted to bring about 75 doses and we had to argue with the pharmacy. They were having more challenges with other churches and we told them this was a highly organized church. We got them to up the doses to 200. Within 1 hour of opening up the sign-up sheet, we had 200 people registered. Of the 200 who registered, 197 people showed up. And of the 197 who showed up, all but 7 came back for their second dose. 4 of the 7, by the time that they were supposed to come back for their second dose, had gone to their local pharmacy to get it already. And we continue to do follow-up with the 3 out of 197. That's pretty good odds. And it shows the advantage of partnering with a trusted group like a church that can get individuals healthy by getting the message out. And with that, Tony, we'll turn it back to you to close us out. Thank you for all the great comments in the chat. And thank you for allowing DeJuan and myself to present today.
So thank you both, Daniel and DeJuan, for your time to present to everyone today. Also, thanks to all of our attendees for taking the time to attend our first keynote session. Starting at 1:15, you have the option of attending one of 2 presentations. There's Enhancing Trust and Inclusion in Medical Research Among Diverse Populations, Reflections from a Researcher, Librarian, and Health Educator, presented by Aisha Langford, Doris Vieira, Carolyn Aird, or you can attend Beyond the Paper, Sharing an Impact of Digital Research Objects, presented by Lisa Federer. Regarding evaluation of our programs, tomorrow at the end of the symposium, you will see a brand new tab added to the conference platform labeled Evaluation. Clicking that will take you to REDCap so that you can do an evaluation. And after you've completed the evaluation, you'll see the steps that you can use to earn your 10 MLA CE credits. Thank you all, and we hope you enjoy the rest of the symposium. I don't know if we have time for another question, unfortunately, but I do thank everyone for all of the comments that you shared in the chat box. I can try and save them, and I will share them with you, Daniel and DeJuan, so that you can see some of the comments that were saved, and if we can locate them through the chat in the vFairs platform, you can contact them if you'd like. So thank you all, and have a great rest of the time with the symposium. Thank you all.
Thank you.